Well, hello. Welcome to our short video on adding value to provider compensation. I'm Eric Andreoli with Healthcare Strategy Group, and if you don't know, here at Healthcare Strategy Group, we're a consulting firm, and we exclusively focus on management and consulting services for employed physician networks. So through our hands-on experience and thought leadership, we've identified 8 key elements that make a high-performing physician network. And aligned compensation is one of those 8 key elements. And so that's what we're going to talk about today. And specifically, as I mentioned, we're going to talk about the need to add value-based metrics to your compensation plans. So through the course of the next 10 to 15 minutes, we're going to briefly answer 3 questions. And I do mean brief, because each of these questions has long answers that really depend on your market, your organization. But what we want to do today is broach these questions, begin to answer them, and hopefully get you thinking about why this is necessary. Why is it necessary to think about changes to your compensation plan? What types of compensation plans are required for success? So what parameters, what things do you need to do to make sure that you have a successful compensation plan? And then lastly, the hardest question, how can you actually do this? How can you design and implement a new compensation plan that will work in the future value-based reimbursement environment? So diving in, thinking about the first question, the why is it necessary to do this? And really, it's necessary. The short answer is that this is necessary because the transition to value is finally happening. Since the implementation of the Affordable Care Act, you've heard consultants, policy experts, folks on the news, you've heard everybody talking about the transition from a fee-for-service world to a value world. So you've heard about the transition from volume to value, whatever terminology you want to put on it. You've heard people talking about it for years and years and years. Up until recently, however, it's been more talk than action. Many organizations were uncertain about the likelihood of this transition actually happening, or more importantly, uncertain about the timing of when this transition is going to happen and what they can do about it and what they need to be doing about it in the next couple of years. But that uncertainty and that doubt is starting to change, and really it's starting to change because there's been some key programs and some key announcements that have been accelerating the pace. So just thinking about the last year, the last 6 to 12 months, CMS and the federal government have put a lot of pressure on the pace of this transition, specifically with a couple programs that they've recently announced. So when we think about what's happened in the past 6 months, we think about the repeal of the sustainable growth rate and everything that CMS did as a part of that repeal. So as a part of that repeal, they introduced the merit-based incentive payment system, which is going to start in 2019. So this is a program that kind of mimics what's been happening on the hospital side in terms of value-based purchasing. It takes a couple of existing and convoluted programs on the physician practice side and consolidates them into one package deal with a clear pathway to participation. And although there's a lot of details still being worked out, the mechanics of this plan are much easier to understand, and the pathway to participation is much easily understood. And so because of that, everybody's looking at what's happening in 2018 and 2019 and beyond and understanding that the practice revenue from their physician enterprise will be affected by some of these value metrics. And the merit-based incentive payment system, MIPS as it's called, is really driving that belief. Another program is the alternative payment model incentive, and so this again, it's part of that SGR, the SGR fix. And so for physician practices, if they don't want to participate in MIPS and they have some sort of alternative payment model, if they're participating in an ACO or if they're a patient-centered medical home or something else, there's actually incentives for the physician practices to participate in those programs. So again, CMS driving people towards value. Again, CMS, not part of the SGR repeal, but a different program, CMS proposed a hip and knee bundled payment initiative, and so that's another thing that's got people worried. It's moving people away from fee-for-service and towards value, specifically for replacements of hips and knees. And so those types of things are really solidifying in people's minds that this transition to value is coming. There are other drivers as well, not just CMS and government drivers, but there are market-specific drivers. So we're hearing clients in specific markets really worry what their competitors are doing. So that's that health system and hospitals. So we see in specific markets that maybe hospitals or large health systems are really forming their own insurance companies, and that's really pushing the drive to value. Commercial payers in specific markets are getting really aggressive about taking value-based contracts or adding value incentives into the payment contracts. Also, employers in specific areas are getting more and more aggressive about being self-insured and finding lower-cost providers to service their self-insured networks. We're seeing employers move to more narrow network type situations, and again, all those things, they're finally happening, and it's really causing in people's minds to solidify that we really are moving towards this value-based approach. So if that's the why, and once we have made that case for the why, and once we have talked about that case, then we have to then ask the next question, which is, okay, so if this is coming, and if we do need to do something about that, what do we need to do? What types of plans do we need to start to implement? What do we need to focus on? And what do our plans need to do to make sure that we as a physician organization and our physicians are successful under this new environment? And there's really three broad categories of things that we think a compensation plan must do in the new environment. And the first is to encourage physician leadership, the second is to build a foundation for value, and the third is to focus on the team-based provision of care. So we'll talk about each one in a little more detail. So that first key concept, the encourage physician leadership. So if we think back to the fee-for-service environment, the goal there was to have your physicians spending as much clinical time as possible, as much patient contact time. You wanted them in the office, in the operating room, generating volume, because that's how you got paid. If you had medical directorships, sometimes they really didn't mean much. It might have just been a way to provide supplemental income to a physician. If you did have shared savings or process improvement programs, there was really no way to share that with the physicians. Under the value-based environment, however, clinical leadership will be required. Some of these programs are extremely complex. You have to have clinical knowledge to navigate your way through some of these quality programs, and so because of that, you need to make sure that your compensation plans allows and encourage physicians to have this leadership. Specifically, you might need physicians to lead care process evaluation or redesign efforts. You might need physicians to be stewards of quality metrics, to really understand the metrics and then to focus on improvement efforts for quality metrics. You also might need physicians to participate in key committees, whether that's IT or patient satisfaction. You need the physician input in order to make sure you continue to be successful in a value-based world. So when you think about how that applies to your compensation plan, you have to be careful, because in a purely work RVU-based plan, anytime you take your physicians out of the clinical setting, they might be penalized from a compensation standpoint. So you might have to make some adaptations to ensure that your physicians are not penalized and actually rewarded for their leadership input. So in order to accomplish this, we see people using either designated administrative time for key physicians, maybe as-needed payments for physicians who might just be on committees or things like that. And for groups of physicians, maybe key groups like cardiology or orthopedics, we see kind of co-management style incentives where you would actually assign the group of physicians to have a management role in the leadership of the service line, and then you might attach some quality metrics to the outcome and performance of the service line, and that's becoming very popular as well for key groups. So again, each one of those things could require a lot more discussion, but we're just trying to give you a taste of all this today. So the next key concept is to build a foundation for value. And so when you think about what do you need in terms of being successful under a value-based environment, you need to be able to measure and manage your quality metrics extremely well. And so at the bottom of this page here in this box, you can see the capabilities needed for quality measurement and management. So you have to have a mechanism for physician input. You have to have the right IT infrastructure and data analysis resources. You have to have reporting and communication platforms, a way to distribute to your physicians the quality dashboards, the performance on quality metrics. You also have to have feedback and process improvement systems. So in terms of making things better and adjusting to the results of quality, you have to have processes and systems in place to deal with all this. And a lot of organizations that we interact with aren't quite there yet. And building these capabilities takes time. And so because of that, you do not want to jump into paying for quality immediately. You don't want at the end of your physician's contract where they have zero value-based incentives now, then to go all of a sudden where now they're 20% of their compensation is at risk. You don't want to do that. You want to gradually increase the amount of physician compensation that's at risk. You want to time those increases to be consistent with the physician tolerance. Measuring quality is new for a lot of physicians, and so they need to get comfortable with the concept. You need to make sure that you time your increase with the capabilities of your systems, both your IT systems and your infrastructure systems, and perhaps most importantly, you need to make sure you time your increases with the changes to your revenue stream. If your payers are not being very aggressive on their contracts and you still have fee-for-service style contracts, there's really no need to accelerate the change in your physician compensation as much. On the other hand, if your payers are really beating you up and really knocking on your door to have more value-based incentives and the payers are trying to accelerate that change, you might need to be a little quicker and a little aggressive at the rate you introduced value-based compensation and quality payment into your physician contracts. So that's what we mean by building a foundation for value and quality. So the next key consideration is to focus on the team-based provision and care. And so we hear a lot of people talk about moving from cowboys to pit crews. That's kind of one of the in vogue terminologies and sayings, but really what people are talking about is under the fee-for-service environment, the quote-unquote cowboy environment, physicians generated work RVUs independently, they practiced independently, their training was more of an independent training, and because of the way RVUs were generated and paid, this actually could cause competition between physicians in the same practice, and so because of that, collaboration usually happened in spite of the compensation plan, not because of the compensation plan. But going forward under the value-based environment, when you hear people talking about, well, we need pit crews, what they're talking about there is the concept that population management may be coming, and because of that, a single physician working in a silo can really not effectively manage any sort of substantial population size. And so because of that, you need to make sure that you give your physicians the tools and reward them for working together. Other complicating factors in terms of a compensation plan in a team-based environment is that if you have a team-based or if you have a multidisciplinary approach, it makes work RVU assignment kind of difficult for people who participate in multidisciplinary cancer committees and things of that nature. That's a little tough to determine how you get paid in terms of work RVUs on those. So you might need something else, or you might need to rethink work RVU models in those situations. Also complicating factors, quality outcomes really are going to depend on multiple specialties. So when you think about value-based purchasing measures such as surgical care improvement projects or some of the readmission rates especially, each physician that comes into the hospital might have multiple physician specialties that are providing care. And so the quality measures that come out of that really touch multiple specialties. And so because of that, you have to have all those specialties working together. So in terms of applying this to compensation plans, what we see people doing is we see work RVU pooling has become very popular. So that addresses the issue of competition I was talking about earlier. So what we see here is for groups of physicians or physicians and advanced practitioners in the same practice, they really start to be judged on not the individual work RVU production by the physician, but the work RVU production by the whole team, and that might include a couple physicians or some physicians and advanced practitioners. Another thing we're seeing people use is group-based quality scoring. So instead of saying, Dr. Smith, we want you to have quality measures X, Y, and Z, and we're going to measure you independently, what we see people saying is the quality score of the whole group will then determine what the quality payments and what the compensation payments are for all the physicians in that group. We also see people using citizenship bonuses for physicians who are going above and beyond and who are really doing that team-based approach. Another thing we're seeing people rethink is the way they pay supervision for advanced practitioners. So this is important because generally the per AP, per month approach is used, but we really see the most successful organizations rethinking that and saying, well, can we introduce incentives to the physician based on how the advanced practitioner they're supervising is working? And that actually builds a lot of teamwork and can be helpful in those situations. So moving on, unfortunately, we've answered the easy questions. The why and the what are more of the easy questions. The harder question is, how can you actually do this? How can you change your compensation plans and make such, I don't want to say drastic, but such important changes to your compensation plans without making all your physicians mad, and with doing it correctly, and with doing everything I talked about earlier that's important? How can you do all that? And it's really important to do it correctly. You don't want to be haphazard about this. Physician retention and physician recruitment, those will suffer if you're haphazard about making changes to your compensation plan. So you need a plan, you need a strategy for how you are going to address these changes, how you're going to actually change your compensation plan. And so we like to think of a plan, a strategy in a couple different phases. So when you set out to change your compensation plan, you have to start in the discovery phase. You have to ask yourself, what are we really trying to do? What are the goals? You have to examine your own organization and say, what are our capabilities? You have to say, you have to ask, what are our physician tolerances for this type of things? Do our physicians need education? You have to ask, how do our current contracts stand right now? You have to have a very good understanding of when your contracts are expiring, the timeline of that, and that'll help you determine and develop an implementation plan for how you're actually going to roll out your new physician compensation plan. And then you can move into the building phase. And so this is really where we think about, okay, what are the best practices? If we want to move to value, what does that look like? What are the best practices for that? But also, what are other ways? What are other options, and what are the advantages and disadvantages of each option? And most importantly, what will actually work for this group? And collectively, working with physicians and working with everybody in the room together, building the compensation plan so you actually have physician buy-in during that building phase. And then very important is the testing and implementation phase. So you have to ask yourself, how will the selected plan actually affect each physician? You have to do financial modeling. You have to understand, will the plan be feasible for the organization? And you actually have to develop an implementation timeline. And prior to the physician compensation plan actually going live, we always recommend a testing phase, almost like a shadow phase or a ghost plan, if you will, where you continue to update the physicians on, once we move to the new plan, here are your values, or here are your quality scores, here's how you're performing, here's what your expected compensation would be, and you continue to communicate with the physicians as you get closer to the rollout of the new plan. So that way when the plan goes live, there's no surprises. Your physicians are used to seeing the numbers, they're used to being measured on them, and there's no surprises, and you keep your physicians happy. So again, that's very brief. We understand that there's probably a lot more questions that have been posed. We've probably posed more questions than we've answered, but that's our goal. Our goal is to get you thinking about what you need to do to change your compensation plan. If you want additional resources, we have a lot of those. So in terms of thought leadership, we produce a lot of thought leadership, both around compensation, but around all of the 8 key elements that were up on the page earlier that I mentioned. We have physician strategy news, newsletter. A lot of the concepts I've talked about today, well, we've made into an ebook guide, adding value to physician compensation. So that's on our website. And of course, we always offer consulting services. So in terms of compensation plan development, advisory, redesign, all that type of stuff we do. Also ad hoc things like acquisition support, contract assessment, and physician leadership program development as well. So if you have more questions, feel free to contact us. Feel free to seek out our thought leadership. We hope this time has been very helpful for you, and hope you have a good day.